Let's talk about restrictive and obstructive lung diseases. Now, anytime you have lung pathology, lung inflammation, your lungs respond in different ways. Sometimes they respond by stiffening. We call it restrictive lung diseases. Sometimes they respond by creating a blockage, an obstruction. We call it obstructive lung disease. When you have a blockage or an obstruction, you can't breathe out, forcefully breathe out. There's an obstruction there. And so all that air gets kind of trapped and expands your lungs. Your lungs get more full of air. We talked about it in our previous videos, different ways we can measure, our lung health or lung volume. We said the first way is just to measure your ability to breathe in and out normally, right? Let's draw it out. So we had a regular breath. We said you can breathe in extra deeply, breathe out extra deeply, right? Our normal breath, we call our tidal volume. This extra deep breath in was your inspiratory reserve volume. This extra deep breath out was your expiratory reserve volume. And then you had a little bit of air you just couldn't breathe out. We call that your residual volume, right? And how did obstructive lung disease change this? Well, if you can't breathe out, then you have trap there, air trapping. And so your volume is going to be a little bit higher on the graph. You just have a little bit more air. Then we said we had another measurement of lung health. Not only measuring how much you breathe in and out, but how much you can forcefully breathe in and out. How you can use this muscle to forcefully breathe in and out. And we said it looked kind of like this, where you take a deep breath in, and then you breathe out as hard as you can. And we said within 1 second, you should breathe out about 80%. We call that our forceful expiratory volume in 1 second, or FEV1. FEV1. Right? Our FEV1. And the ratio of FEV1 to FVC, we said would be around 0.8 or 80%. Well, in obstructive lung diseases, you can't really forcefully breathe, right? So your FVC will be decreased, but the main problem is there's an obstruction there. The main problem is you can't forcefully breathe out. When you try and breathe out, there's an obstruction, it closes, yeah? And so FEV1 goes way down, way down. So if you mess with the ratio where the numerator goes down further than the denominator, then the ratio will be very low. All right, so it'll be less than 0.08. And that's kind of like the hallmark, all right, the hallmark in this graph. In this graph, it's just you have more air in your lungs. So in this graph, you have more residual volume because you have more air in your lungs. And by proxy, we said that increases your total lung capacity. Yeah. Also increases, I forgot to mention another capacity term, it increases your residual capacity, which is just ERV plus RV, so your functional residual capacity. All right, so just some air trapping in your lung. These are changes in normal measurements that you need to know, commonly asked. So this one's a big one, and then these are big ones. Okay? Now you can see it through these measurements. You can also see it through VQ mismatch. How does it affect your VQ? Does it affect your perfusion, your Q? No. Does it affect your V, your ventilation? Yes. We said you can't really breathe in and out as you should, you ventilate as you should. So it decreases V, which means the number will be approaching 0, okay? So these are all kind of lab measurements, but if you want to do a physical exam, you'll see all that air trapped in their lungs. They're going to have this barrel chest. Their chest is going to be huge. All this air trapped in the lung. When you percuss, it's going to be hyperresonant. And you're going to keep percussing all the way down. You're like, whoa, how far does this guy's lungs go? It's like this dude's more lung than human. The lungs are going to be so expanded. You can see it on chest x-ray. All that air will trap in the lungs and expand their lungs, and their diaphragm will keep getting pushed down and down and get a flattened diaphragm. So our hyperinflated lungs plus flattened diaphragm. You gotta be able to recognize this. You gotta be able to recognize it on chest x-ray. Shows up all the time. So that's all the signs of obstructive lung diseases. Now, what exactly are obstructive lung diseases? What makes up obstructive lung disease? There's about 4 or 5 different diseases that causing obstruction in your lungs, and we just group it all into obstructive lung diseases. The first two I want to talk about is due to smoking mainly, smoking. And smoking can cause emphysema, and it can cause chronic bronchitis. Chronic bronchitis. We'll talk about emphysema first. Anytime you have a bunch of smoke and crap in your lungs, it's going to cause inflammation. It's going to cause inflammation. Anytime you have stuff in your alveoli, neutrophils are going to go in and clean it up. And you're thinking, great, that's fantastic, that's what we want. The bad thing is that neutrophils also release something called elastase. I'll denote it as in purple, elastase. And elastase will break down your alveoli. You're thinking, well, that's bad, but your body's not dumb enough to just let it do that on its own, right? It has some sort of counterbalance. And the way it counters this is that your liver will pump out a protein called alpha-1 antitrypsin. Trypsin is kind of a protease elastase so it's an anti-elastase, and alpha is just his name. So we'll pump this out, and that'll go into your blood and block this elastase. And so your neutrophils can do its job without breaking down your alveoli. Do its job without breaking down its alveoli, and that way you can counterbalance it. All right, everything's good and well. However, in smoking, that balance is thrown off. In smoking, you have so much gunk from all that smoke, that just nasty stuff that goes into your alveoli, that it causes an overwhelming amount of neutrophils to come in. You have so many neutrophils coming in. Increased neutrophils, and that throws out the balance. Also, smoke by itself blocks alpha-1 antitrypsin. And that also throws out the balance. So now you have elastase that's free to roam. And that just destroys your alveoli. So I'll just make it look destroyed. So that turns your alveoli from this nice elastic alveoli into our paper bag, where it's loose and floppy. And because it's loose and floppy, when you try and exhale, it'll lose its support and it'll just collapse on itself and cause an obstruction. And that's kind of the name of the game, obstructive lung disease. So it will collapse. All right, alveolar destruction equals collapse. Smoking is the biggest cause of emphysema, but let's say a kid comes in, he's like 24, never smoked a pack in his life, and has emphysema, all the signs of emphysema, hyperinflated lungs, the decreased FEV, FEC ratio, all this stuff, and you're thinking, well, it's not due to smoking, what could it be due to? The second common cause, so the first common cause is smoking, the second common cause is hereditary. This is due to hereditary deficiency in alpha-1 antitrypsin. You don't ever make alpha-1 in the first place. And so nothing balances all that neutrophilic elastase. Your neutrophils are going hog wild. Nothing's balancing it. All right. So that causes emphysema. They want you to know that it is autosomal dominant disorder, and that is co-dominant. That's very important because not a lot of things are co-dominant. You have blood types, which is co-dominant, but also this is co-dominant. You have MM phenotype, genotype, which is normal. You have ZZ, which is abnormal. It causes the deficiency. And then you can have MZ, which is kind of a expression of both because it's co-dominant. Okay, expression of both because it's co-dominant. So the history will be completely different. Talk about a young person never smoked that has emphysema, and that's a dead giveaway. And then they might ask, what else are you expecting to find? You're thinking, what? Something else you're expecting to find is things like cirrhosis, or they might say lab findings, things like elevated ALT, AST, liver damage test. Why is that? Well, we said your liver makes this alpha-1 antitrypsin, and in hereditary defects, you're not making it. What happens is that you make an abnormal form, and it never leaves the liver in the first place. It gets stuck in the liver, and it builds up in the liver and becomes hepatotoxic. And so you get emphysema plus cirrhosis. What a horrible combination. So a young patient comes in with emphysema, you're thinking alpha-1 antitrypsin hereditary deficiency, not smoking. And then what else you should look for? Signs of cirrhosis. History is different. They might ask you, well, what part of the lungs do these two different types affect? They affect different parts of the lungs. So let's just draw out our respiratory zone. We said our respiratory zone had your respiratory bronchioles with its alveoli, and then we had your alveolar sac with all of its alveoli, right? The scientific name to call this whole thing is acinus. An acinus. In smoking, it will affect your upper lungs first, because that's, I guess, the first thing that comes in contact with all those toxins, all that smoke, all that damage. So it'll affect your upper lungs. And in the acinus of your upper lungs, all that smoke, all that damage will first hit your respiratory bronchioles. The central part. We call this centroacinar, or res bronchioles. And then your neutrophils will come in and destroy this part, cause emphysema of this part. Okay. And let's just reset. These are respiratory bronchioles with all your alveoli. Now, hereditary deficiency of alpha-1 antitrypsin will only affect the part of your acinus? No, it's going to affect your entire acinus. So I write pan-acinus. Affect your entire acinus. Is it only going to affect the upper part of your lungs? No, it's going to affect your entire lungs. So it will be upper and lower. The lower part is a dead giveaway. Also, it'll affect your lower a lot, because your lower, we said, is more perfused. When we talked about VQ mismatch, it has more perfusion. And we said neutrophils come out. How do neutrophils come out? They roll out of your blood, don't they? So if it's more perfused, you have more neutrophils rolling out, more neutrophils going into your lungs, more neutrophils releasing elastase, destroying your lungs. So lower lobe, dead giveaway. Pan-acinar, dead giveaway. That is hereditary deficiency. And then one more kind of unrelated is periseptal. This is actually not really related to emphysema at all, but we throw it in here anyways. This is when you have a destruction very close to your pleura, and it forms a bulle, kind of a blister. And that bulle can pop and cause spontaneous pneumothorax. So blow a hole right open, you get a spontaneous pneumothorax. And when it's not actually really linked to emphysema, it's not linked to pathology at all. It can happen in a normal adult. Usually they say a tall, skinny male can have this. They seem to be more predisposed to it. So I'll say tall, thin male. You might have learned in your school that tall, thin males have a tendency to have these spontaneous pneumothoraxes. Now you know why. Periseptal bulle. And that is emphysema. That's how smoking affects your respiratory zone. How does smoking affect your conducting zone? That's going to be chronic bronchitis. Okay? How does smoking affect your conducting zone? What's important in your conducting zone? We say your conducting zone conducts air, warms and humidifies air, but there's also something very important. It has that mucociliary elevator or escalator that helps us clear our lungs, right? Helps kind of trap gunk, make sure nothing bad goes in. So let's just draw the components of your little escalator thing. We said we had our pseudostratified, ciliated, columnar, right? And we also had our mucus-producing glands. And we said mucus trapped gunk, and then your cilia kind of beat it up to your throat until you cough it out. Right? Well, smoking will destroy this because it's a toxin. And actually destroy it so bad that it becomes squamous. It goes squamous metaplasia. And you lose your cilia. So you lose your cilia and now it's become squamous. All that irritant will make your mucus glands freak out. It says, I need to trap more of this stuff. There's so much stuff, I need to undergo hyperplasia of your glands. And make more mucus to trap all this gunk, especially since my cilia friend's destroyed. And so it will undergo hyperplasia, now it looks like this. Yeah, it's larger, more. And the combination of which causes a whole bunch of mucus stuck in your lungs, causing an obstruction. That's why it's part of obstructive lung diseases. Increased mucus equals obstruction. And we have all this increased mucus, you're gonna be coughing all the time. This is why smokers, chronic smokers cough all the time. Chronic inflammation of your bronchi and your conducting zone causes this chronic cough over 3 months for over 2 years. Can you imagine coughing for that long? So it just causes this chronic cough. And we can measure how thickened these glands are, how much mucus they're producing via the Reed index. Usually if we look at our lumen, your mucus glands will make up about less than 40%, or 0.4. But during hyperplasia, they'll grow, and now they're over 50%. So that's the number you should be looking for. And that's how you know, okay, there's chronic inflammation, there's chronic hyperplasia of these mucus glands. So that's how smoking affects your respiratory zone, that's how smoking affects your conducting zone. And this chronic bronchitis of your conducting zone, I really like this chronic part because it demonstrates something. If you look into the lab findings, that chronic destruction will cause chronic hypoxia. And when you have chronic hypoxia, you release a hormone that helps you kind of get more blood in to kind of deliver more oxygen. That's EPO, to get increased EPO and polycythemia. That chronic hypoxia of your lungs, what happens when your lungs get hypoxic? They have hypoxic vasoconstriction. You undergo hypoxic vasoconstriction. And you will start to develop pulmonary hypertension. Pulmonary hypertension, because your vessels are too small. And your heart's feeling that hypertension, that vasoconstriction. And when your heart tries to pump blood into your lungs, it won't be able to. It's feeling all that pressure, that vasoconstriction. Yeah? And so you will start to develop heart failure. Heart failure. Which side? What side of the heart pumps blood to your lungs? It'd be right heart. Right heart failure, or cor pulmonale. Remember, that's isolated right heart failure. And this will enlarge and get strained as it's trying to pump blood into your vasoconstricted lungs. All right? I think that's all I want to talk about for emphysema and chronic bronchitis. Let's talk about something called bronchiectasis. Bronchiectasis is very similar to chronic bronchitis, where you have chronic inflammation of your conducting zone and a ton of mucus. The difference is that bronchiectasis usually has a different etiology. So let's talk about bronchiectasis. Bronchi, that's your large bronchi, so you know it's going to be in your conducting zone. Ectasis means dilation. So what causes that chronic inflammation in the first place? Usually from chronic infections. What causes chronic infections? Why is this patient predisposed to chronic infections? A lot of times it's from things like cystic fibrosis. Could be things like HIV. Could be things like cartagenars. Cartagenars is a loss of your dining arm and you lose your so I'll just write it down. Cartagenars, loss of your dining arm. And this causes dysfunctional cilia, so you lose your mucociliary escalator, and that way you're predisposed to more infections. This is also important because you have dextrocardia, your heart's on the other side. That's always a fun fact that I like to point out. So all these different things can cause you to have increased infections. And when you have this chronic inflammation, you have bronchiectasis, yeah? You have all this mucus, you have all this dilation, and then the patient will just keep coughing up cupfuls of sputum. The first bronchiectasis patient I ever saw was in the hospital and actually had cupfuls of sputum. And then the doctor asked me, what do you think that patient has? And I saw all these cupfuls of sputum, and I said, bronchiectasis, just based on the fact alone. So they just keep coughing up all this mucus and sputum, and that causes the obstruction. Yeah. I don't think there's much I want to say about this directly, but I want to talk about CF for a second. CF is always linked to bronchiectasis. Cystic fibrosis is a mutation in your cystic fibrosis transmembrane conductance regulator, which makes a protein that puts a chloride channel in your membrane. All right, transmembrane chloride channel. Chloride channel. And in a lot of your organs, it'll pump chloride out into secretions. And by osmosis, when you have a ton of ions in these secretions, it'll draw water in and kind of thin it out. Thin secretions. Make things watery. All right. So that's what happens in your organs. In your skin, it's a little bit different. In your skin, it's kind of the opposite. You have chloride out here, and it wants to come inside. And so it'll go through the channel and come inside. So your skin is kind of like the opposite. Your skin takes in chloride instead of pumps things out. Now, if you have a mutation in this, then what do you think will happen? If you have a mutation in this, what do you think will happen? Well, in your organs, you won't be able to pump out chloride, and so you won't be able to thin your secretions. Your secretions become thick, rock hard. In your skin, you won't be able to take in chloride, and now chloride is going to be all over your skin. That's what happens in mutations. The most common mutation is going to be a 3 nucleotide deletion in the position of amino acid 508. And that codes for phenylalanine. When you delete phenylalanine, then you have a mutation. Sometimes a fancy way of calling this is delta F508. F stands for phenylalanine at the position of 508. Okay? When you have a deletion in it, you make a misfolded chloride channel. The misfolded chloride channel never makes it out of your Golgi apparatus. This gets destroyed in your Golgi apparatus. So destroyed in Golgi. Never makes it to membrane. Never makes it to membrane. Never makes to membrane. And if it never makes it to the membrane, then it can't do these functions. It can't pump out chloride, and now you have thick secretions. It never takes in chloride in your skin, and now you have chloride all over your skin. Okay? So let's just talk about the thick secretions first. As a newborn, thick secretions in your GIT causes your first poo, your meconium, to become rock hard. And sometimes you can't pass that meconium. You can't poo for the first time. And that causes a blockage we call meconium ileus. Meconium ileus. All right, so you can't poo as a newborn. As you grow older, your GIT secretions aren't going to get any thinner. You get thick pancreatic secretions. So your pancreas can't release things. It's too thick. It gets clogged up and blocked up. And when it gets clogged up and blocked up, you get pancreatic insufficiency. You can't digest things, so you have malabsorption and failure to thrive. Sooner or later, this block-up will destroy your pancreas, and you'll get diabetes because you can't make insulin. Now let's move on to the organ that we're talking about here, your lungs. You have thick secretions in your lungs, your mucociliary escalator is destroyed, and so you have chronic infections of your lungs. Chronic lung infections. Normally, it starts out as Staph aureus, but as you grow older, it becomes Pseudomonas. And Pseudomonas, honestly speaking, you just can't get rid of after a while. Pseudomonas causes that chronic inflammation, just causes that cupfuls of sputum, and actually respiratory failure is the most common cause of death. So, right, most common cause of death. All right. You can also affect your nose, cause nasal polyps from all the inflammation. So, all right, nasal polyps. And then lastly, it can affect your reproductive organs. In women, it causes really thick cervical secretions and makes it hard to get pregnant. In men, it causes infertility due to the loss of the vas deft. Why it causes a loss of vas deft, I'm not quite sure. But because you have a loss of vas deft, the infertility rate for men is much, much higher than women. It's about like 95%. All right, you're missing some very, very vital plumbing here. Now, how common is cystic fibrosis? It's actually pretty common. Even though it's an autosomal recessive trait, that means you need to have 2 parents to have it. Yeah, so you need to have 2 parents to have it. But it's relatively common, seen more in the white population. And so let's just say 2 people with the trait come together and have a baby, and you're worried that the baby might have cystic fibrosis. So you do genetic tests, and also when a baby's born, this is kind of mandatory in all states, I think. You do cystic fibrosis screening. The way we screen for cystic fibrosis is that we look for something called immunoreactive trypsinogen. You might recognize the enzyme trypsinogen from the pancreas, and they're absolutely right. When your pancreas gets attacked by cystic fibrosis, it will release this. And then if you pick it up in the newborn screening, you're thinking, okay, the kid might have cystic fibrosis. To confirm this screening, you do sweat tests. We said that on your skin, you can't reabsorb chloride, and so you have a lot of chloride, especially sodium chloride, stuck in your skin. That we call a sweat test. And so if you have an elevated amount of that chloride on your skin, that's kind of confirmatory. Sometimes the way they ask it in the question is that the mother will kiss the baby and the baby will taste salty. Baby is salty. I don't know if I should write that. That's not very scientific, but the baby is salty. Yeah, so they'll kiss the baby and say, baby tastes salty. The reason the baby tastes salty is, again, all that chloride stuck on the skin can't get reabsorbed in cystic fibrosis. Okay, I think that's all I want to talk about on cystic fibrosis. There's one more, and that is asthma. There's one more obstructive lung disease, and that is asthma, but we won't talk about it in this video. Asthma deserves a video all on its own. So until then, I'll see you next time. Thanks.